Assalamualaikum, selamat pagi, siang, dan sore. Perkenalkan, nama saya Agnesia Pelita Sihaloho, Prodi S1 Keperawatan, Kelas 2B dari University Horizon Indonesia, Kelas. Pertama-tama, kita akan membahas tentang penyakit TBC yang tersebar di Indonesia. Lalu, mari kita simak bareng-bareng ya teman-teman. Yang pertama ada pengertian TBC ataupun disebut dengan tuberkulosis yang juga dikenal dengan TBC, yaitu penyakit paru-paru yang akibat tuman Mycobacterium tuberculosis. Lalu TBC akan menimbulkan gejala berupa batuk yang berlangsung yang lebih lama ataupun lebih dari 3 minggu, dan biasanya juga ada pemberdahak dan juga terkadang mengeluarkan darah. Yang kedua ada etiologi penyakit TBC-nya. Lalu penyebab etiologi terbanyaknya adalah tuberkulosis yang besar selama 30 pasien, yaitu 38,3%. Itu gambaran hasil fototorak berdasarkan lokasi terbanyak Dextra 64 pasien ataupun 60,64%. Dengan riwayat penyakit penyerta tersebar adalah tidak adanya penyakit penyerta sebesar 55 pasien ataupun disebut dengan 51,9%. Dengan pemeriksaan biokimia didapat 92 pasien tidak memiliki pemeriksaan biokimia. 5 pasien memiliki pemeriksaan biokimia dengan kadar retaka dengan glukosa 46 plus 23,33 mili ataupun DL, dan 7 pasien memiliki pemeriksaan biokimia protein dengan kadar rata protein 2 plus atau 0,44 gram per DL, dan 2 pasien memiliki biokimia LDH dengan kadar rata yaitu LDH 179 plus 49 dengan IU ataupun L. Dengan diagnosis citologinya terbesar adalah kategori SMER jinak sebanyak 65 pasien ataupun 61,3%, dengan etiologi penyakit infeksi terbanyak 80%. Lalu yaitu ada infeksi saluran kemih dengan tifoid, bakteriokemia, tuberkulosis, serta otitis media. Dengan korban terbanyak yang ditemukan pada pembiakan darah, pembiakan urin, dan pembiakan feses dengan berturut-turut. Lalu adalah Tuberkulosis dengan epidermidisis ataupun Escherichia coli dan Escherichia coli dengan patogen. Ketiga, tanda dan gejala utama TBC. Batuk selama lebih dari 2 minggu merupakan gejala utama diagnosis tuberkulosis yang disertai dahak. Dengan adanya gejala yang menyertai adalah batuk berdahak, nafsu makan berkurang, serta berat badannya menurun, ataupun berkeringat malam, atau tidak beraktivitas dan tidak ada tanda-tanda ataupun infeksi. Adapun gejala yang menyertainya itu batuk yang mengeluarkan darah ataupun nafsu makan yang menurun, serta penurunan berat badan dan berkeringat pada malam hari atau tanpa aktivitas, dan tanda-tandanya yaitu infeksi. Lalu ada pengobatan penderita PDC, yaitu pengobatan penderita TBC pada populasi penelitian ini adalah seluruh penderita BTA, yaitu positif di rumah sakit Merauke sebanyak 320 penderita pasien TBC. Sampelnya menggunakan teknik purposif atau sampling dengan jumlah 30 penderita TBC. Lalu instrumen penelitiannya yaitu menggunakan dengan kuesioner dan observasi. Dan kesimpulannya yaitu terdapat hubungan yang sangat kuat antara dukungan sosial atau keluarga dengan keberhasilan pengobatan tersebut. Dan diperkirakan bagi penderita tuberkulosis paru agar perlu berobat secara terus-menerus tanpa terputus walaupun telah merasa lebih baik ataupun sehat. 5. Adapun jalan penurunan, yaitu kerentanan akan tuberkulosis paru ini terjadi karena daya tahan tubuh dengan pasien yang rendah yang disebabkan oleh gizi ataupun terlalu buruk, lelah, kedinginan, serta cara hidup yang tidak teratur. Oleh karena itu, penyakit tuberkulosis paru lebih banyak ditemukan. Lalu pada golongan masyarakatnya, yaitu di mana keadaan masyarakat yang kurang pengetahuan atau disertai dengan sikap dan perilaku yang buruk terhadap upaya pencegahan dan penularan tuberkulosis paru, sedangkan pengetahuan yang sikap dan perilakunya yang sangat menentukan dalam pencegahan tuberkulosis paru. Cara pencegahannya, pertama-tama ada salah satu cara penularan TBC paru adalah melalui udara. Hal ini berarti bahwa salah satu risikonya terjadi itu penularan adalah melalui kontak dekat, yaitu dari lingkungan ataupun dengan keluarga. Dengan penelitian ini bertujuan untuk melihat hubungan antara pengetahuan tentang pencegahan penularan TBC paru atau upaya pencegahan dalam keluarga dan dukungan keluarga terhadap pencegahan penularan TBC paru tersebut. Di sini saya akan ada video dan foto TBC sebagai berikut.
Tahukah kamu, secara global diperkirakan sekitar 1 juta anak di dunia menderita TB paru setiap tahunnya. Penyakit ini sangat menular dan mematikan. Tuberkulosis paru adalah suatu penyakit menular yang disebabkan oleh bakteri Mycobacterium tuberculosis. Bakteri ini umumnya menyerang paru-paru, tapi juga bisa menyerang ke bagian tubuh lainnya, seperti kulit, tulang, usus, kelenjar getah bening, dan juga otak. TB paru dapat ditularkan melalui percikan dahak atau droplet saat penderita batuk atau bersin. Penularan berisiko tinggi terjadi pada anak jika anak memiliki faktor risiko sebagai berikut. Yang pertama, gizi kurang. Kemudian yang kedua, lama kontak dengan keluarga, teman, kerabat terdekat yang mengidap TB. Yang ketiga, tidak mengikuti imunisasi BCG. Dan yang terakhir adalah faktor lingkungan. Lingkungan seperti apa sih yang menjadi faktor risiko tinggi? Lingkungan yang lembab dan kurang sinar matahari. Tanda dan gejala TB paru pada anak meliputi batuk berdahak lebih dari 3 minggu, demam lebih dari 2 minggu tanpa penyebab yang jelas, penurunan berat badan tanpa sebab yang jelas, penurunan nafsu makan, rasa sakit di dada, sesak nafas, lesu, dan kurang aktif. Cara mencegah TB tertular pada anak adalah dengan memperbaiki gizi dengan makanan-makanan yang bergizi dan dapat mempengaruhi sistem imun, dan secara tidak langsung menyebabkan daya tahan tubuh lebih meningkat. Kemudian, hindari kontak langsung dengan orang lain atau keluarga yang mengidap penyakit TBC. Kemudian, optimalisasi imunisasi BCG, dan dari faktor lingkungan, hindari lingkungan yang lembab, ventilasinya harus diperbaiki di dalam rumah, dan sinar matahari yang cukup. Jika Anda menemukan suatu kondisi yang sama dengan penjelasan di atas, segera periksakan anak, keluarga, serta sanak saudara Anda ke layanan kesehatan terdekat. Hindari TB anak karena anak adalah harapan bangsa untuk masa depan. Agar negara Indonesia tercinta ini terbebas dari penyakit TB.
About 2 billion people worldwide are infected with Mycobacterium tuberculosis, often just shortened to tuberculosis or simply TB. 2 billion is a ton of people, but even though they're infected, that doesn't mean that all these people have symptoms. The vast majority, about 90 to 95%, aren't even aware that they're infected. And this is because usually the immune system can contain it, such that it's not able to multiply. It often remains latent or dormant, as opposed to active, which usually causes symptoms and can be spread to others. If the host's immune system becomes debilitated at some point down the road, like with AIDS or some other illness, or as a person grows older, it can be allowed to reactivate, or basically wake up and become very serious, especially if it spreads throughout the body. Mycobacteria are an interesting bunch. They're slender, rod-shaped, and need oxygen to survive. In other words, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that they can hold on to a dye in spite of being exposed to alcohol, leaving it bright red colored when a Zeal-Nielsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and survive on dry surfaces for months at a time. Now, Mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now, we breathe in all sorts of virus and bacteria all the time, but we've got defenses that take care of most of them. For one, air that we breathe in is turbulent in the upper airways, and drives most bacteria against mucus, which is then cleared pretty quickly. Ultimately though, TB can avoid the mucus traps and make its way to the deep airways and alveoli, where we have macrophages that eat up foreign cells, digest, and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytize them, or essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the Mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, somebody has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma, essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks kind of like cheese. This area is known as a gone focus. TB also gets to hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the gone focus infection, and causes caseation there as well. And together, this caseating tissue and associated lymph node make up the characteristic gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. The tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on X-ray. This calcified gone complex is called a Ranke complex. In some cases, although a scar is left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they're walled off, they remain viable, and are therefore still alive, but they're just dormant. If and when a person's immune system becomes compromised, like with AIDS or with aging, the gone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and TB, being anaerobe, prefers areas of greater oxygenation. Since they were previously exposed, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis. This time though, it tends to cavitate, or form cavities, which can allow the bacteria to disseminate, or spread through airways and lymphatic channels to other parts of the lungs, which can cause bronchopneumonia, but it can also spread via the vascular system and infect almost every other tissue in the body, called systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organ affected. Kidneys are commonly affected, resulting in sterile pyuria or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis, the lumbar vertebrae, causing Pott disease, the adrenal glands causing Addison's disease, the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD intradermal skin test, sometimes known as a tuberculin skin test, MAN2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin tests simply mean that the patient's been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you do not need to show up again to have the test read like you do with a PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to many children around the world to prevent disseminated TB. After doing a screen test with PPD or IGRA, anyone with a positive result typically gets a chest x-ray to look for signs of active TB disease. In patients with symptoms like fevers, night sweats, weight loss, and coughing up blood, or hemoptysis, it's important to collect samples from either the sputum or via bronchoalveolar lavage, which is where the bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted, and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look for evidence of Mycobacterium tuberculosis. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combinations of anti-TB antibiotics like isoniazid, rifampin, ethambutol, and pyrazinamide, which results in patients being non-infectious to others usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy, or DOT, where somebody watches and confirms that you're taking the medication. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You might hear of MDR-TB, or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which is incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is to get an effective treatment. It's super important to make sure that the drugs being used will work against the specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy, so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB, called pretomanid. According to recent studies, a combination of pretomanid, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally, and is also very well tolerated compared with other XDR-TB drug regimens. Alright, as a quick recap, tuberculosis, or TB, is an infection caused by Mycobacterium tuberculosis that mainly affects the lungs. 3 weeks after the primary infection, the immune system tries to contain the infection created by a granuloma, and the tissue in the middle undergoes caseous necrosis, resulting in an area called a gone focus. TB also extends to nearby hilar lymph nodes, causing caseous necrosis there as well. The gone focus plus the affected lymph node makes up the characteristic gone complex. If the immune system becomes compromised, like with AIDS or older age, the gone focus can reactivate, and the infection can spread to one or both upper lobes of the lungs, where it forms cavities. From cavities, bacteria can disseminate to other parts of the lungs, causing bronchopneumonia, but it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB starts with a PPD intradermal skin test, or with an IgRA blood test, and a chest x-ray can identify signs of active TB disease. In patients with fevers, night sweats, weight loss, and hemoptysis, a sputum sample can be stained, cultured, and PCR can be done to look for Mycobacterium tuberculosis. Treatment of active TB includes a combination of antibiotics, given for several months, and special regimens are used for MDR-TB and XDR-TB.
Dan ada juga 2 sesi pertanyaan dengan Google Form. Yang di bawah ini, pertama ada POSTEST, lalu kedua ada PRETEST. Terpustakanya sebagai berikut. Terima kasih semuanya telah menonton video saya. Semoga bermanfaat bagi kita semua. See you, jaga kesehatan ya. Bye-bye.